All right, it is 12 o'clock, and we have a very full, packed agenda for you today. So we will go ahead and get started. We are very lucky to have Dr. Jonathan Gabison here, who is a practicing family medicine physician here at the University of Michigan with expertise and specialty in both diabetes and obesity. And so we're very lucky to have him here to talk to us today about the updates that the ADA has pushed forward this year for 2026. And so we'll hand it over to him in just a moment. But first, I'll walk us through our CME slides. And so if you are a practicing clinician, make sure to sign up for CME so that you can get that out of this session. Go ahead and text the code 89634 to 833-256-8390. And then you'll need to complete the required online evaluation by April 2nd. You can also do this through the portal at Corewell Health East and follow that link. These slides will be provided to you after this meeting. So if you are not able to get this done while on this slide, do not panic. You will have an opportunity to do this after the fact. Note, you can still complete the evaluation even if you do not text this code by March 22nd. Just the texting option requires to be done by then. Next slide, please, Dr. Gabison. All right, so a couple of disclosures of financial relationships. So Dr. Gabison has a consultant role with Eli Lilly, and Dr. Lauren Oshman, who is the MCT2D program director, who is not presenting today, but who is the course director for all of our learning community events, has stocks in publicly traded companies, including Abbott, AbbVie, Johnson & Johnson, Merck, and Organon. Next slide. And then this is all of the CME opportunities for which this is provided: medicine, nursing, pharmacy, social work, and dietetics. All right, with that, Dr. Gabison, I will hand it over to you.
Hello, everybody. It's very nice to present this topic to you. And we're going to get right into it because we have a lot to discuss. So before we dive into the updates, I want to make sure everyone knows how to read the ADA's recommendations. They use a grading system from A through E, skipping D, so nobody feels like they failed. A is your gold standard: large, well-powered, randomized controlled trials and solid meta-analyses. When you see an A recommendation, the evidence is strong. B means we have RCT data, but there may be some limitations, or we're relying on well-done cohort studies. Still, there's good evidence, but it's just not bulletproof. C is where the data starts to get thinner. Maybe there's uncontrolled studies, case series, conflicting evidence. The recommendation is there, but you should know the foundation is softer. And then there's E, which is expert consensus. This is basically the smart people getting in a room and agreeing that something makes sense, but we don't have the trials to back it up yet. As we go through today's updates, I'll call out the evidence grade so you can judge for yourself how much weight to put behind each recommendation. So here's our game plan for the day. We'll talk about heart failure and MASLD updates or MASH updates, new evidence for combination therapy in chronic kidney disease, some obesity management updates, and then we'll wrap up with some quick fire updates. This is the updated pharmacologic treatment algorithm for the American Diabetes Association. You've probably seen this before. It looks mostly the same, but there are 4 specific changes that I'm going to highlight. Just kind of a general overview. At the top, you see healthy lifestyle behaviors. That's the core of any intervention. Diabetes self-management, education, and support. Again, that's a core of any intervention. The way that this algorithm is broken down is essentially what secondary benefits do these medications offer. If they offer these secondary benefits, let's start with these medications for our patients. So it looks at cardiovascular disease, heart failure, chronic kidney disease, and obesity management, as well as MASLD, MASH. So the first thing I want to highlight on the bottom left, there's a little black box, and that's a terminology shift. They moved away from using the word A1C in these places as a sole framing, and now they use glycemia more broadly. When we talk about CGM updates, you'll see probably why they decided to do that. Box 2, that fluorescent green in the middle of the screen, that is for patients with heart failure symptoms, whether HFrEF, reduced ejection fraction, or HFpEF, preserved ejection fraction. SGLT2 inhibitors are now clearly called out. This isn't brand new evidence, but the algorithm now makes the pathway more explicit, and they're separating HFpEF and HFrEF. The third box below that are for patients with symptomatic preserved ejection fraction heart failure and obesity. The recommendation is you can use an SGLT2 inhibitor for them and or an incretin-based therapy with proven heart failure benefits. So we're seeing GLPs carving out a specific lane in the heart failure space when obesity is a cofactor. We'll go very much in depth on that. And then finally, you see that star. They removed the language about continuing SGLT2 inhibitors until dialysis or transplant. And we'll come back to this when we talk about kidney disease updates. And then on the bottom is MASLD and MASH recommendations. They didn't really change anything here on the algorithm, but we'll get into some updated trials that highlight new evidence. This is one of the more notable updates this year. The ADA is now explicitly recommending incretin-based therapy for symptomatic heart failure, and they highlighted it in both the pharmacologic and cardiovascular sections of the guidelines. The message, if your patients have type 2 diabetes, obesity, and symptomatic heart failure with preserved ejection fraction, incretin therapy should be part of this plan. Both dual GIP GLP-1 receptor agonists that has both the dual GIP GLP-1 receptor agonist and GLP-1 receptor agonists are recommended. The grading difference reflects the trial design, not necessarily clinical preference, and we'll see why in the next 2 slides. And I think the key takeaway here is this is irrespective of hemoglobin A1C. This is a heart failure recommendation. It is likely a weight loss recommendation and not necessarily a glucose recommendation. So the SUMMIT trial is the new trial driving this grade A evidence for tirzepatide or GLP-1 / GIP. 731 patients with heart failure with preserved ejection fraction and obesity were randomized to tirzepatide up to 15 milligrams weekly versus placebo, and they were followed for 2 years. These were pretty sick patients. Their KCCQ score, which is a heart failure symptom score, was in the low 50s, which is high. Their walk distance was about 300 meters on average, and nearly half hospitalized for heart failure in the prior year. The enrollment in the study, the ejection fraction was 50% or higher. And I think one important design choice for this study is that the elevated BNP was not required for enrollment. That matters in practice because obesity-related HFpEF, the natriuretic peptides, are often suppressed by adipose tissue. So a normal BNP does not necessarily rule out significant heart failure in these patients. This is a practical pearl for your clinic, and it's something I didn't know before working on this presentation. So now the results. So looking at the Kaplan-Meier curve on the right, the curve separates early, around 24 weeks, and stays separated. The composite cardiovascular death or worsening heart failure was reduced in the treatment arm. Hazard ratio was 0.62, with heart failure hospitalization specifically cut by 56%. Patients also reported meaningful symptom improvement with the improvement in the KCCQ advantage score over placebo. Beyond the primary endpoints, patients lost on average about 14% of their body weight. They had 39% drop in CRP. That tells me this is not just volume reduction. We are addressing systemic inflammation, which is driving the disease. One caveat, though, is tirzepatide is not yet FDA approved for heart failure. Current indications are for type 2 diabetes and obesity, but the ADA felt that the evidence was strong enough to build explicit recommendations around it. This is a slide from last year. I talked about it, and I'll talk about it briefly now. So this is STEP HFPEF, so a semaglutide trial for heart failure with preserved ejection fraction and obesity. Patients in this trial had an ejection fraction of 45% or higher. There was significant improvement in symptoms, weight, and function, and you can see the separation in both curves sustained through 52 weeks. The reason I'm showing it again is context for the evidence grading. This trial was designed to measure symptoms and weight and not hard cardiovascular outcomes. Heart failure events were a secondary endpoint, and that is why semaglutide earns a grade A for symptoms, but a grade B for events. Compare that to Summit, which was designed and powered for the hard outcomes. The symptom improvement and weight loss are remarkably similar between the two drugs. The grading difference is about the trial design, not clinical superiority. The ADA recommends you can use either one, but the grade evidence is a little different. And then before we move on, I just want to pause on a practical point. So these recommendations apply to symptomatic heart failure with preserved ejection fraction. So how do we identify these patients? The classic symptoms are exertional dyspnea, fatigue, exercise intolerance, lower extremity swelling. Ejection fraction is preserved, usually 50% or higher. And here's the challenge. BNP can be normal, like I said before, especially with our patients with obesity. So a normal BNP does not rule this out. These patients are already in your clinic. They may not carry the heart failure diagnosis. They may be labeled as deconditioned or out of shape. So if you have a patient with type 2 diabetes and obesity who cannot walk as far as they used to, maybe they get winded going upstairs or have leg swelling, think about HFpEF, get an echo, because if they fit this phenotype, we now have grade A evidence for treatment. So to kind of bring this whole heart failure picture together, here's how to think about it from a point of care standpoint. SGLT2 inhibitors remain the foundation for any patient with type 2 diabetes and heart failure, whether they have HFrEF or HFpEF. That has not changed. What is new is the second lane when your patients also have obesity and symptomatic HFpEF. Incretin-based therapy now has its own place. The algorithm is becoming more phenotype driven. You are not just asking, does my patient have heart failure? You're asking what kind of heart failure? Do they have obesity? And which therapy matches that specific combination? So now let's move on to the liver disease space, MASLD and MASH. Before we get to the treatment updates, let me set the stage a little bit. Who are we worried about? So MASLD is extremely common in our type 2 diabetes population. Some estimates suggest over 60% of patients with type 2 diabetes have some degree of fatty liver disease. The patients we need to identify are those progressing toward MASH and fibrosis, because that is where the morbidity and mortality risk climbs. Risk factors include obesity, metabolic syndrome, elevated liver enzymes, elevated inflammatory markers. If your patient has type 2 diabetes and obesity, assume they're at risk until proven otherwise. How do you screen? The ADA supports non-invasive testing. FIB4 is a very simple calculation using age, AST, ALT, and their platelet count. If a FIB4 is elevated, the next step is vibration-controlled transient elastography. That's a mouthful, a fiber scan, which is measuring liver stiffness. Together, these can help stratify our patients into low or intermediate high-risk fibrosis group without a biopsy. The key is you need a hepatologist to start this workup. FIB4 can be calculated on all of your type 2 diabetes, or your patients with type 2 diabetes. Identify those high-risk patients because now we have treatments to offer them. The liver disease recommendations got upgraded this year for your type 2 patients with type 2 diabetes with MASLD and overweight or obesity. GLP-1 receptor agonists are grade A, specifically semaglutide. For the sicker patients with biopsy-proven MASH or high fibrosis risk, on non-invasive testing, GLP-1s are now the preferred agent, also grade A. Pioglitazone and dual agonists are alternatives. And for the higher risk patients, combination of pioglitazone and GLP is an option. The upgrade from prior years is driven by the first phase 3 trial showing histological benefit, which we'll look at next. The practical message is if your patients have type 2 diabetes, fatty liver disease, this should be driving your choice of glucose therapy. So the ESSENCE trial is the reason why semaglutide or GLP-1s earned a grade A for MASH. 1,197 patients with biopsy-confirmed MASH and significant fibrosis, either F2 or F3, were randomized 2-to-1 to semaglutide 2.4 milligrams weekly versus a placebo. And this was the first phase 3 trial designed to test whether this medication could produce histological improvement in metabolic-associated steatotic hepatitis. Both primary endpoints were met. Nearly 63% had MASH resolution without worsening fibrosis versus a third on placebo. Over a third had fibrosis improvement. These are histological changes on biopsy, not just lowering liver enzymes. These patients lost about 10.5% of their body weight. ALT was cut more than half. This is what led to the FDA approval of semaglutide for MASH with moderate to advanced fibrosis. So a few important caveats before we move on. This is an accelerated FDA approval. That means it's based on the histological surrogates, MASH resolution, and fibrosis reduction on biopsy. We do not yet know if those changes translate to fewer liver-related clinical events like decompensation, liver cancer, or death. The second part of the trial is the extension to 240 weeks, and the goal of that part of the trial is to answer those questions. Second, we can't fully separate how much of this is a direct liver effect versus weight loss. Patients lost more than 10% of their body weight, and notably, a separate trial in patients who already had compensated cirrhosis showed semaglutide reduced liver fat, but did not improve fibrosis. So again, if they had compensated cirrhosis and they were given semaglutide, it reduced their liver fat, but did not improve fibrosis. So there may be a window where this treatment works, pre-cirrhotic disease, and a point where it does not once they start developing the cirrhosis. Third, the practical gaps. The trial enrolled patients by biopsy. In practice, we will be selecting patients with non-invasive testing. We are still validating that those patients respond the same way. The trial also had limited diversity and did not assess body composition, which I think matters when our patients lose a significant amount of weight and may already be at risk for sarcopenia or reduced muscle when they have liver disease. So I think this is real progress, but it's not the final answer. From a clinical perspective or practicality, I will be using these treatments in my patients with MASH that are pre-cirrhotic with type 2 diabetes, but setting expectations accordingly. All right, let's shift to obesity management. Over half of patients with on GLP-1s for obesity stop the medication within the first year. The number one reason people cite is the GI side effects. And a lot of that is driven by the titration schedule, which was designed for clinical trial efficiency, not for real world tolerability. So now the ADA is explicitly saying, let's slow down. Let's use smaller increments. And the max dose for weight management is not always the goal. If your patient is benefiting at a lower dose and tolerating it, that may be the right dose for them. The priority is keeping them on the therapy long term. For my patients, I want to know if these medications are having an impact on their eating behaviors. Is it impacting their food noise? Is it allowing them to have more controlled eating habits? If they are not eating, if they're experiencing side effects that are prohibitive, like nausea or vomiting, I want to stay at the lowest dose possible, or even go down in dose. So here's the data. This was a standard. This trial looked at standard label titration of getting to 1 milligram of semaglutide in 8 weeks, with a flexible protocol, comparing it to a flexible protocol, which took 16 weeks with smaller increases. If you look at the top graph, which is the black line, or the top graph here, adherence was significantly better in the flexible group, which is the light blue-gray line. And the separation starts early and widens over time. The bottom graph showed that the people on the flexible protocol had about half the nausea days. And the key finding, in my opinion, is that there was no difference in efficacy. People lost the same amount of weight over the course of the 16 weeks. The best dose is the one that your patients will actually tolerate, the ones that they'll actually take. This is a new recommendation. So for the first time, the ADA is explicitly saying use the same obesity management strategies in type 1 diabetes that we use in the general population, including GLP-1s and metabolic surgery. I think this matters because obesity is just as common in type 1 diabetes as the general population. 30 to 40% have obesity, and it carries the same increased cardiovascular and microvascular risk. Clinicians were already doing this. So about 6.5% of patients with type 1 diabetes were already being prescribed GLP-1 receptor agonists by 2023. But until now, there was no formal guidelines to support it. The evidence base is still early. There's a grade B for GLP-1 based therapies and grade C for surgery. But the ADA felt it was enough to make an explicit recommendation. So let's look at the evidence. The strongest RCT data comes from the adjunct trials with liraglutide, about 6% weight loss in these trials. And importantly, there was a fat mass reduction without losing lean mass. But there were real safety signals. Hypoglycemia rates were up 20 to 30%, and ketosis risk doubled a lot. So those findings are why there's caution around titration and insulin management for these patients, and we'll get more into detail on that. Beyond the RCTs, we now have a growing body of real-world data. So there's a 2026 meta-analysis of 13 studies which confirmed weight loss, modest A1C improvement, and meaningful insulin dose reductions. There was a head-to-head real-world comparison in this population showing that tirzepatide and semaglutide both outperformed liraglutide for weight loss at 12 months with no severe hypoglycemia or DKA events. That's encouraging. But again, these are observational studies and they're not powered for RCTs. I want to be transparent about the evidence. Our type 1 or patients with type 1 diabetes were excluded from the major weight loss trials. There's no FDA indication for GLP-1 receptor agonists in type 1 diabetes. The ADA themselves describe this evidence as preliminary, but the direction is clear and prospective cardiovascular and kidney outcome trials are underway. So for now, we can offer these options with appropriate counseling. For metabolic surgery, this carries the C grade. We now have the largest multi-centered retrospective study for patients with type 1 diabetes. 162 patients showed nearly 30% total weight loss at 1 year, insulin requirements cut by 57%, and significant improvements were found across lipid markers. Greater weight loss predicted greater insulin reduction, and A1C improved modestly but significantly. There are, again, important limitations in this population. So number one, this is retrospective data. There are no RCTs for metabolic surgery in type 1 diabetes. A1C improvement was modest despite dramatic weight loss, and A1C effect had been inconsistent across prior studies. Long-term data beyond 1 year is limited. So surgery is an option, but it's highly individualized and carries that grade C recommendation. I think this is the slide that matters most for our practice. Starting a GLP-1 in a patient with type 1 diabetes is not the same as starting one in a patient with type 2 diabetes. There are 4 things to watch for. So number one, hypoglycemia. As their appetite drops and weight comes off, their insulin needs will fall. Do not wait for lows to happen. Proactively reduce their basal and bolus doses early. Number 2, titration. I would not follow the type 2 diabetes dose escalation schedule, just like the prior slides with obesity management and titration schedule. Go slow, monitor closely with each increase. Third, nutritional risk. These medications suppress appetite significantly. Your patients with type 1 diabetes still need adequate carbohydrate intake. If they are not eating enough, their ketone risk goes up. So counseling them on checking ketones might be helpful. Fourth, plan for discontinuation up front. Again, we've seen over half of patients who start incretin therapy for weight management will stop it within a year. If that happens for these people, insulin needs will go back up. Set that expectation from the start, and when possible, plan for long-term use to prevent weight gain or weight regain. Now on to kidney disease updates. So there's 2 important updates here, and we'll get into them. The new recommendation this year for patients with type 2 diabetes, significant albuminuria and CKD with eGFR between 30 and 90. The ADA now says you can start an SGLT2 inhibitor and finerenone at the same time on a background of a maximally tolerated ACE inhibitor or ARB. So why the combination? Why now? These 2 drug classes work through completely different mechanisms. The SGLT2 inhibitor reduces hyperfiltration and intraglomerular pressure. Finerenone blocks mineralocorticoid-driven inflammation and fibrosis. Both independently slow CKD progression and reduce cardiovascular events. And neither effect depends on glucose lowering for kidney disease. So there is a biological rationale for additive benefit. And then there's a practical argument. Albuminuria, I think this is a big take-home point if you didn't know this already. Albuminuria is the strongest modifiable predictor of CKD progression. Every month a patient spends with uncontrolled albuminuria while we sequentially add therapies, they're not getting it back. So potentially starting both simultaneously gets you to maximal kidney protection faster. That's the rationale. Let me show you the trial that tested it. But before we get there, I want to make sure everyone is familiar with finerenone. It is a non-steroidal mineralocorticoid receptor agonist. It's third generation, so prior generation spironolactone and eplerenone. It is more selective. It does not cause hormonal side effects. There are two large trials, Fidelio and Figaro, with over 13,000 patients combined that showed reduction in both adverse kidney and cardiovascular outcomes in patients with type 2 diabetes with chronic kidney disease. It has been in the ADA and KDIGO guidelines since 2022. Here's how finerenone compares to the older MRAs you may already know. There's higher receptor selectivity. It's balanced tissue distribution between the kidneys and the heart. There's less hyperkalemia risk. There's minimal blood pressure effects, and there's no anti-androgenic side effects. The trade-off is the cost, but it is the only MRA with demonstrated outcome benefit in diabetic kidney disease. So this is the confidence trial. It's the first randomized controlled trial to test simultaneous initiation of an SGLT2 inhibitor and finerenone. There were 818 patients enrolled in the study. They had type 2 diabetes, chronic kidney disease, and significant albuminuria, all on maximally tolerated ACE inhibitor or ARB. There were 3 arms, finerenone alone, empagliflozin alone, or both together for 180 days. Looking at the graph, all 3 lines come down for change in urine albumin to creatinine ratio. But the combination of finerenone and SGLT2 inhibitor, empagliflozin, dropped it even further. There was a 52% reduction in UACR, roughly 30% better than either drug alone. On safety, potassium went up about 0.27 millimole per liter with combination, and hyperkalemia incidence was about 9%. There was an initial eGFR dip that reversed after discontinuation. I think some important context, this is a phase 2 trial with a surrogate endpoint. We do not yet have hard kidney outcomes, but albuminuria reduction is one of the strongest predictors of long-term kidney protection. And the magnitude here is very compelling. So let's think about practical considerations, right? So step 1, always maximize your ACE or ARB. Every major CKD outcome trial was done on that foundation. Do not skip it. Do not layer additional therapies on suboptimal RAS blockade dose. From there, you are layering based on your patient. So SGLT2 inhibitors and GLP-1, specifically semaglutide, work through completely different mechanisms. They have indications in these populations. And the kidney protection is independent of glucose lowering. Real world data shows that adding one to the other reduces both cardiovascular and kidney events beyond monotherapy. The confidence trial now gives us direct evidence that starting SGLT2 inhibitors and finerenone simultaneously produce greater albuminuria reduction than either alone. There's no head-to-head trial telling you which to start first. So use your clinical judgment. If your patient has significant cardiovascular risk or heart failure, that might drive your choice. If albuminuria is the dominant concern, that might change your calculus, right? The point is these therapies are complementary and we should be thinking about combination for a higher risk CKD patients, not just picking one and hoping for the best. Here's an equally important point. Do not pull these back as kidney functions worsen. So for GLP-1 receptor agonists, they are now preferred for glycemic management in advanced chronic kidney disease with an eGFR under 30. You can continue them through dialysis. Just use agents that do not depend on kidney clearance, which I assume none of us use. The ones we can use, semaglutide, dulaglutide, liraglutide, tirzepatide. We should avoid exenatide and lixisenatide, which I have not used in my practice since I started practicing. For SGLT2 inhibitors, you can start them with an eGFR as low as 20. Once started, you can stay on them even as eGFR drops below that threshold. The glucose lowering effect fades, but the kidney and cardiovascular protection persists. The only reason to stop is when dialysis actually starts, or if the patient can't tolerate it anymore. All right, so we're going to shift to a few quick hitting updates, and then I'll take time for some questions. So more of our patients of childbearing potential are on GLP-1s or incretin therapy for weight management or diabetes. So this matters for primary care. The ADA updated the narrative this year to be more explicit. Discontinue these medications before attempting conception. Why? There's no randomized control trials in pregnancies. And also there are animal studies that raise concern about fetal growth restriction on these medications and skeletal abnormalities for the fetus. The FDA has not approved using these medications during pregnancy, so the default is to stop. Now look at this table. So this is from the largest cohort study to date, over 50,000 pregnancies. GLP-1 receptor agonists showed no increased risk of major or cardiac malformations compared to insulin. That is very reassuring, but I want to clarify where they're getting this data from, what the periconceptional exposure means in this study. It was defined as filling at least one prescription from 3 months before the last menstrual period through the end of the first trimester. So this is capturing women who are on the medication around the time of conception and into early pregnancy, which is exactly the scenario we worry about with unplanned pregnancies. I think this is really good to know for counseling. If a patient comes to you already pregnant while on a GLP, the human data so far is reassuring. But this is observational. It's not a randomized control trial. So it's not enough to change the recommendation. We should still discontinue before conception. Given how many patients are now on these medications, a lot of which we don't know are on this medication because they're getting it from outside places, hopefully we will see more robust safety data in the next couple of years that give us clearer guidance. But for now, we stop at least 2 months before conception. And we know we need to stop these medications before pregnancy, but this JAMA study from 2025 shows us that discontinuation itself carries risk. So women who stopped these medications before pregnancy gained about 3 kilograms more than women who were never on them. And that excess weight was associated with higher rates of preterm delivery, gestational diabetes, and hypertensive disorders. So this should change, or at least this should make us be thinking about how we approach the transition. Stopping the GLP-1s is not just a checkbox. It's a risk period that needs its own management plan. Starting that contraception conversation early, build in enough time to get glycemic control on insulin before conception, counsel your patients that weight rebound is likely and plan for it. The worst scenario is a patient who stops these medications, has no glycemic plan in place, gains weight rapidly, and then conceives with uncontrolled glucose. This is preventable, and we should be planning for it. All right, so some CGM updates. So the ADA significantly broadened CGM recommendations this year. Previously, the language was to consider CGM early. Now it's an explicit recommendation at diabetes onset and for a much wider population than just patients on insulin. 3 groups in the recommendation. So there's patients on insulin. This is a grade A. Patients on non-insulin therapy that can cause hypoglycemia, so sulfonylureas is what I think about there. That's a grade B. And then the broadest category, anyone on any diabetes treatment where CGM helps with management, also a grade B. That third group opens the door to using CGM as a behavioral and educational tool, not just a safety monitor. I think the other major shift is, and this has made its way into the algorithm, CGM metrics are now elevated to co-equal status with hemoglobin A1C. So time in range, time above range, time below range are all indicators. These aren't just supplementary data points. The ADA is saying you can assess glycemia status with A1C, with CGM, or both. So why did the ADA expand this? The evidence is there. So there was a meta-analysis of 12 trials that showed CGM reducing A1C about 1/3%, so about 0.31 in patients with type 2 diabetes, regardless of medication type, not just the insulin users. Patients on incretins and oral medications benefited too. On the safety side, a trial in insulin-treated patients showed CGM reduced time spent in hypoglycemia by about half an hour per day, and that adds up and matters for patient safety and quality of life. And in practice, many of us have seen it. You put a patient on a CGM, and they're also on metformin and a sulfonylurea, and suddenly they understand what that after-dinner glucose spike looks like. It changes behaviors in a way that A1C every 3 months never will. I think the most compelling long-term data comes from this VA study, which followed over 2,700 CGM users for 5 years. Higher time in range was associated with 23% lower risk of all-cause mortality. That supports the ADA target of greater than 70% time in range and gives us a reason to pay attention to these metrics beyond hemoglobin A1C. Here's the frustration. I'm sure we all have experienced this. The evidence says use it broadly. The ADA says use it broadly. But for our patients who are not on insulin, most insurances still will not cover it. I think there's a real disconnect between guideline recommendations and what we can actually do in our clinics. At MCT2D, this is something we won't stop continuing to advocate for. Broader CGM coverage is a priority because the evidence and the clinical benefit is there. But until coverage catches up, many of our patients are left out. So what can you do now? Know the recommendations exist. Use it to support prior authorizations when you can. Document your clinical rationale. And then for patients who can access a CGM, even if it's for short-term use, it can be a powerful educational tool. One more CGM note for our older patients. The evidence shows benefit even in those not on insulin, particularly for reducing hypoglycemia. That matters because hypoglycemia in older adults leads to falls, hospitalizations, cognitive decline. But be practical about the implementation. It may take longer for older patients to get comfortable with the technology. So possibly involve caregivers early. I think that's something that can be helpful. Assess whether your patient can manage the device independently. If not, remote data sharing with a care partner can make it work, or a loved one. The CGM does not have to be managed by the patient alone to be useful, and that's part of what this study showed. All right, this is the last update. So new this year, the ADA now addresses metformin for medication-induced hyperglycemia. For certain cancer therapies, so the PI3K and mTOR inhibitors, there's now evidence that metformin can prevent and treat hyperglycemia associated with these drugs, or that these drugs can cause. Most of us are not prescribing these drugs. We're not prescribing PI3K inhibitors or mTOR inhibitors. That's oncology's job. But if oncology refers a patient back to us with new hyperglycemia, or you notice a patient is on one of these medications, know that metformin is there's evidence that metformin and that insulin there's evidence that metformin is first line, and that insulin and sulfonylureas should be avoided, especially in patients on PI3K inhibitors. More relevant to our daily practice, I think, is glucocorticoids, which is also updated in the ADA guidelines, or the ADA primary care update. It now says to consider metformin to prevent hyperglycemia in high-risk patients starting steroids, particularly at higher doses or longer courses. The shift is from treating hyperglycemia, overall the shift is from treating the hyperglycemia after the fact to preventing it proactively. The bigger picture for me for primary care is to start thinking about metformin not just as a diabetes drug, but as a tool for medication-induced metabolic disruption. The common thread across all these drug classes, cancer therapy, steroids, antipsychotics, is insulin resistance. And metformin targets that mechanism directly. It is safe, it's familiar, it's cheap. So for glucocorticoids, think proactively. If you're starting a high-risk patient on a longer steroid course, consider metformin at the start, rather than waiting until they develop prediabetes or diabetes. And I would extend the same logic to antipsychotics too. Olanzapine, clozapine, they can cause significant insulin resistance and weight gain. This is not that the ADA doesn't speak specifically to those medications, but I think there's supporting evidence from the psychiatry literature, and the mechanism is similar. Let me leave you with the big themes. Okay, so that was a lot of information. The guidelines are becoming more phenotype driven. We are matching therapies to specific clinical profiles. Do not be afraid to layer therapies, and do not pull them back as disease progresses. Be thoughtful with GLPs, individualize the doses, go slower, plan transitions carefully, push for broader CGM access. The evidence and guidelines are ahead of insurance coverage, and then use those recommendations to advocate for your patients. I need a drink of water. That's a lot of stuff. Any questions? I'm going to open up the chat. It looks like there's a lot of comments.
No actual questions in the chat yet, Dr. Gavison. I've been monitoring. Just a lot of great conversation and discussion.
All right. Curious what everyone is saying.
One question just came through in the chat from Mary Pilarski, the very bottom.
Can you repeat why do we not need BMP? Why was it not valid? Also, is there a threshold for starting a GLP or tirzepatide with CKD like there is for a SGLT2 inhibitor? So it's not that BNP is not valid. It's just in the study for I'm getting my medications confused. They didn't use BMP as a threshold for consideration of HFPEF because people with obesity, the adipose tissue can disguise or can falsely lower that BNP number. So they used symptoms, and they used echo findings, and they used ejection fraction. And then also, is there a threshold for starting GLP or GIP/GLP with CKD like there is for SGLT2 inhibitors? No. So what I think about for GLP or GLP or GIP/GLP is in chronic kidney disease, especially at lower eGFRs below 30, it is going to be the best medication for glycemia. So if they have an A1C of 9.3%, I'd want to get them on a GLP. I know it can help prevent progression of chronic kidney disease. And I know it's going to be best for their glycemia.
There's one question that came through as a follow-up to a different line here from Dr. Haber. Also, when is the time to use finerenone instead of an SGLT2?
So I'm not seeing it. I saw another comment, not that I don't see finerenone being used likely due to cost. So I'm not seeing it that often too. I think I'm going to start trying and seeing if it will be more commonly covered. What was the question again, Jake?
Yep, it was from Dr. Haber. When is it the time to use finerenone instead of SGLT2 inhibitors?
Higher albuminuria. So the higher that, like, that's really what the study was highlighting is combination therapy, SGLT2 plus finerenone. Both of them by themselves are going to have benefits for albuminuria, but together it's going to be much more robust. And we know that albuminuria is the biggest predictive factor for kidney disease progressing. So to me, essentially what that means is if their UACR is greater than 100, I probably want to try starting dual therapy if you want to get a number.
Great. And then a follow-up from Nicole, who had another portion of her question that said, any comparison data with spironolactone for UACR reduction, as I don't see that used so much.
I went to this slide. There's limited evidence. So you see on this slide the MRA comparison, clinical evidence is a minus. So I don't see a lot of data on it either. I haven't done a deep dive into those studies if there are any. I think about spironolactone more for the heart.
And I think we're down to Roberta's comments, so we're back in order if you wanted to keep going.
So Mary Pilarski said, did you say that UACR is the biggest predictor for worsening chronic kidney disease? Yes. I've seen it improve in patients that complied with treatment recommendations. Yes. That would be a good thing. Am I confused with something, Mary? Mary, if you can follow up on your question, because so is it a one-way street? So UACR is the worse someone's albuminuria is, the more likely they're going to progress. Their chronic kidney disease is going to progress. So the more we should think about treating them with these agents is my answer to that. And that's going to help reduce the progression of chronic kidney disease. Pioglitazone does not have a role for type 2 diabetes with chronic kidney disease. It's only shown evidence for MASH or MASLD.
And then Dr. Gavison, I know Roberta had a question with regards to HFPEF and MASH and MASLD, but I'm not sure if you had answered that. I missed it.
Okay, so what are your thoughts on slow incretin mimetic titration and not necessarily targeting max dose in the setting of trials using max dose for HFPEF and MASH MASLD benefit? I So I think that's an excellent question. I would say similar, we want to keep people on the medication. What we see is people are more likely to stay on the medication. Also, my personal experience, people are more likely to stay on the medication if they're not having a lot of side effects. And so slow, flexible titration is worthwhile. What I would say is I always like to ask the question if they're having benefits with the medication. So you start them on the first dose of semaglutide, 0.25 milligrams. And then, the questions I always ask my patients are you noticing any side effects, weight reduction, any impact on food noise, right? If they're not having side effects, we can go up on dose. If they are having side effects, we should stay on that dose. If they're not tolerating it at all, maybe we should switch to another agent. Uh, uh, and that's my general approach clinically with those medications. As long as they tolerate it, I'm good with going up. But then the question is, are they eating enough? Right. And so, sometimes people equate not eating with better results. They're going to lose weight because they're not eating anything. That's not what I want for any of my patients, whether it's diabetes or obesity or both, right? I want them to be able to eat the right things. I want to decrease their food noise. I want them not to be able to overeat or not feel like they should overeat. So I will go up as tolerated, and then I'll stay at whatever dose they tolerate it as.
And then Mary did send another clarification. So it seems like I think she's thinking in regards to is progressing UACR possible to reverse? Can a patient's UACR get better with treatment?
Yes. Yes, it does get better. Yes, that's the thought. It does slow progression. The combination trial did not look at long-term kidney outcomes, but there are other trials that show improving albuminuria improves chronic kidney disease outcomes and chronic kidney disease progression. So great question, Dr. Haber. What I would say is if my goal, so again, we're thinking about, this would be a good slide on the graph, but I'm going to try, I should have a slide on the presentation, but I'm thinking about albuminuria when I'm thinking about the combination therapy, right? So if I know that they have a EGFR of 50, so they have stage 3A chronic kidney disease, their A1C is like 8%, our goals, let's say, are less than 7%. They do not have significant albuminuria. I'll have them on the maximally tolerated ACE or ARB, and then I'll probably start an SGLT2 because I'm thinking about glycemia as well as chronic kidney disease protection. They don't have significant albuminuria. I think what would change that equation to me is if their UACR is greater than 100, or if they have macroalbuminuria, so greater than 100 is in the study, and then I would think about starting both. Finerenone alone, I think there's a role in chronic kidney disease without diabetes. I think if they're not tolerating SGLT2 inhibitor, I might start finerenone alone if I'm concerned about their chronic kidney disease. I think cost is prohibitive in my mind too. I hope I answered everyone's questions. I know some of this stuff is confusing. Jake will provide the slides, or MCT2D will provide the slides, and I believe, will there be a transcript, Jake?
Slides will be emailed out tomorrow, and then the recording of the presentation will be available on YouTube. And for anybody that was not able to attend, you can watch the recording on YouTube and answer a short quiz in order to get learning community. event credit. Yeah, slides will be sent out by Lifa Yang tomorrow, as per always, Dr. Haber.
All right, thank you, everybody. Have a beautiful